Okay. Hi, good evening, everyone. I'm Priyanka. I'm an F1 at NUM, and the team at BIMA have kindly asked me to deliver these sessions, and they've been a lot of fun. I'm really thankful to everyone who's attended the sessions and also participated as well, both by asking questions and by participating in the polls. So we're going to do the same of like what's worked before. So I have a bunch of SPAs, and we'll be doing the polls again this time because that worked quite well in the last session. And yeah, feel free to ask any questions that you guys have during the session. I'll try and answer them as best I can. If not, I'll try and look stuff up and let you guys know in the next session. So the topics I wanted to cover today was pain. So we're going to look at ovarian cyst accidents, how they might present to ED or the GP, dysmenorrhea, so painful periods, dyspareunia, pain during sexual intercourse. And then we're going to go through vaginal discharge, STIs, some differential. And we're going to go through contraception, and lastly, fertility and subfertility. And we'll go through PCOS and ovarian hyperstimulation syndrome, how they might present and how you'd investigate and treat them. Okay, so I showed you guys this picture already before, but just a quick recap again. So when it comes to common differential diagnoses from a gynecology perspective, you just want to think of, all the different parts of the female reproductive system. So think of the vagina, the cervix, uterus, and the ovaries, and just think of differentials in relation to those anatomical structures. And then obviously think outside the box, so think systemic, iatrogenic, and physiological causes as well of your gynae presenting complaints. So here's your first MCQ. We're going to get stuck right in. So you've got a 33-year-old woman presents to ED, worsening left-sided abdominal pain. So pain started suddenly 5 hours ago, steadily getting worse, and it started following intercourse. She's unsure about the date of her LMP, and she currently has a coil fitted. So no vaginal bleeding or discharge. On examination, there's no guarding or rigidity, but it's tender on palpation. You've also done a ultrasound scan as well. So what do we think is going on in this case? And remember, the urine pregnancy test is negative. It's another thing. So what's the most likely diagnosis? We'll wait for most of you guys to answer, and then we'll reveal the... Okay, so if you can show the answers now. Great, so most of you guys picked the right answer. So it is a ruptured ovarian cyst. Let's go through some of the features in the history and the examination that made you guys pick ruptured ovarian cyst. So let's go through the history. What in the presenting complaint do you guys think is classic for an ovarian cyst rupture? Sudden onset, yeah. Exactly. Sudden onset, progressively worsening pain. Yes, Namrata. So it's definitely important to do a negative pregnancy, to do a pregnancy test in anyone that comes in with abdominal pain, even if she's got a Mirena coil fitted. Like I mentioned in my last session, if you have a Mirena coil fitted and you do end up getting pregnant, chances of you having an ectopic pregnancy is more likely. The fact that it's following intercourse as well, yes, definitely. That's something that might precipitate either ovarian cyst torsion or a ruptured ovarian cyst. And why do you guys think it is a ruptured ovarian cyst and not adnexal torsion? Because it could be either of those things when someone first presents. Yeah, free fluid, exactly. So what would you see in adnexal torsion? What would you see on your ultrasound scan? You might feel a palpable mass, yes. Do you guys know what type of, yeah, you can see a whirlpool sign as well, yeah. Do you know what type of ultrasound scan they would classically do with torsion? Yeah, so you'd usually do an ultrasound Doppler scan, and you basically see changes in the flow, in the arterial flow to the the ovarian cyst, basically. And you'd also see an engorged cyst as well, because essentially, because you've got all this venous congestion, the cyst basically becomes a lot bigger, and you see that engorgement on ultrasound scan. Whereas if the cyst is already ruptured, then all you're going to see is a, all you will see on an ultrasound scan is free fluid. Good. Why is it not Mittal Schmutz? What is Mittal Schmutz to start off with, and why is it less likely in this case? Yeah, it's pain in the middle of the cycle, exactly. Yeah. And it's not very, very severe pain. It's sort of like pain that's quite manageable. And yeah, it's basically in the middle of the cycle. It's less likely in this case because yeah, she's not sure exactly where she is in her cycle, but she also has a Mirena coil fitted. So, you might start getting like, you might become amenorrheic on the coil as well. So why is it not appendicitis? I think that's quite straightforward. It's left-sided abdominal pain, so it's less likely to be appendicitis because you don't have that migratory pain from central abdominal pain moving to the right iliac fossa. So it's less like it's not going to be appendicitis. So when it's left-sided abdominal pain, it's a bit more straightforward. So yeah, so the answer in this case is ruptured ovarian cyst. So this one's a little bit more sort of complicated because it's right lower abdominal pain, and that's a contested area between surgeons and gynecology, and we're often sort of like struggling when it comes to referring to either of these specialties because you just keep bouncing between them when it comes to like to a female with with lower abdominal pain. So this again has been associated with vomiting since the morning. There's some rebound tenderness, again negative pregnancy test, so you've ruled out an ectopic. Sorry, that sort of answered anyway. Ultrasound scan shows free fluid again, but no other pathology. Raised white cells, raised CRP. What do we think is the most likely diagnosis in this case? I'll give you guys a minute to answer. Okay, so if we can show the answers now. Yeah, so most of you guys answered correct. So in this case, it is acute appendicitis. And what in the vignette or in the question itself made you think it's acute appendicitis over other gynae causes of lower abdominal pain? Yeah, but that could, I guess, RAF pain can be appendicitis. Yeah, so it's RAF pain, but it could be ovarian torsion, it could be an abscess, it could be PID. Associated with vomiting, yeah. High white cell count and CRP, yes. I think you would, with ovarian torsion, you might see a raised CRP because of the inflammatory response, but you're less likely to see a high white cell count as well. Is afebrile usually the case or not? I'm not sure exactly what you mean, Andy. Do you mean afebrile? Why is it not PID? So that is a really good question. It could be PID because she's got the raised white cells, she's got the CRP as well. But I think with regards to the fact that she's got this rebound tenderness on examination, I think in the history itself, it doesn't tell you that she's got any risk factors for PID. She hasn't had any, they don't mention anything about the sexual history. So I think that's another thing why it says what's the most likely diagnosis. Because they haven't given you anything to do with the sexual history, acute appendicitis is more likely compared to PID. And also with PID, you're likely to be a bit more sick, especially if it's something that, if you're having to admit them in hospital, if they are in a lot of pain, then they might have fevers as well with PID, and they might have some discharge. They might have pain during sexual intercourse, all of those things. And they haven't really mentioned that in this. So I think that's why I would say acute appendicitis over PID. And I think you've asked why are they not febrile. So I think, yeah, like as Mohammed said, so you'd usually be febrile if you've perforated, or, if they are febrile, then you're a bit more worried. It's sort of even more of an emergency. Obviously, you would still take this person to theater, but the suspicion of it, if it's perforated, then they're more likely to be a bit more sick with it. Yeah, so you might be febrile, you might be afebrile, so you don't always get that response. Anything else? I think that's everything. But yeah, usually it would be associated with vomiting as well. But I think often the vomiting thing, if someone is in enough pain, they would usually have nausea and vomiting as well. What does free fluid in the peritoneal cavity indicate? So I think it could just be as a result of the inflammatory process. And often a small amount of free fluid is normal. But obviously, in the context of a cyst rupture, it could be from the cyst itself. But it could just be part of the inflammatory process. That could just be why they've got free fluid in the peritoneal cavity. Yeah, so in this case, the answer was A, acute appendicitis, which is just something to like make you guys think that, you know, if it's right iliac fossa pain, then you'd be considering acute appendicitis in addition to all of your ovarian cyst accidents. So just quickly going through ovarian cyst accidents, you've got rupture and then you've got torsion as well. And they both can present quite similarly. So it's acute abdominal pain, usually precipitated by exercise or after sexual intercourse. With ovarian cyst rupture, it can also present with a PV bleed as well. You can get nausea and vomiting. It might present with circulatory collapse, weakness, syncope, and always rule out. So in both sort of, in any acute gynecological pain, you need to rule out an ectopic. So you need to make sure this lady is not pregnant. An ultrasound scan, as we mentioned, would show free fluid. And with regards to management, actually, if they've had a cyst rupture and they're stable, they can sometimes be discharged home on just analgesia. But if they're bleeding, if they're unstable, then they would do a laparoscopy. But I think you'd refer them to gynae, and that would be a decision that gynae would make. But yeah, not everyone needs to have surgery, because sometimes if a cyst is ruptured, then your body just naturally, you know, absorbs that free fluid. But if they're obviously unstable and they've got a lot of blood, if you're concerned about like hemoperitoneum, do you guys know which cysts are hemorrhagic? Which type of ovarian cysts do you find would bleed quite a lot? You can get a lot of blood in the peritoneum. Endometrioma, yes, you can get, so it's because it's got altered blood in it. There's another type of cyst as well that can give you quite a lot of bleeding. Corpus luteal cyst, yes, exactly. So yeah, I saw one on during my gynae rotation, my last rotation, and like there was a lot of, it can bleed quite a lot. And basically these are the cysts. So corpus luteum is something that if you don't fall pregnant, it's sort of just supposed to be, you know, it's supposed to just become smaller. It just gets resorbed and it gets smaller and smaller and it disappears. But sometimes it doesn't. And it can eventually, it can rupture and it can cause quite a lot of bleeding into the peritoneum. Someone has said, sorry, I think I might have missed, but what's the difference between adnexal torsion and ruptured ovarian cyst? So I think when they say adnexal torsion, they just mean ovarian torsion. So that's basically, so adnexa is just anything right next to the, adjacent to the uterus. So adnexal torsion is the same as ovarian torsion. And then ruptured ovarian cyst is when you've got a cyst that basically bursts. So yeah, so moving on to ovarian torsion. I think adnexal torsion is a bit of a weird way, but yeah, it's the same as ovarian torsion from what I understand. And it can present in quite a similar way. So again, you've got the acute abdominal pain during exercise, intercourse. The pain can radiate to the back, thigh, and pelvis. Again, nausea and vomiting. If you've got fever in the context of an ovarian torsion, then it could indicate that the ovary has become necrotic. And again, investigations are the same, but you do an ultrasound Doppler, and that would show a large edematous ovary with impaired blood flow. And essentially with ovarian torsion, do you guys know why we would operate in cases of ovarian torsion? What are we worried about? Fertility, why are we worried about fertility? Yeah, so necrosis, and essentially the lady can lose her ovary because of the torsion. So you want to basically operate as soon as you can, especially if you're worried about torsion. Yeah. And yeah, that's basically the main difference between cyst and torsion. With cyst, you're more likely to get PV bleeding. If you are worried, you can always do an ultrasound scan with Doppler as well, especially if you're considering torsion. And torsion, you should operate on as soon as you can. Whereas cyst, if they're stable, then you can send them home with analgesia. Okay, so let's go through, again, acute abdominal pain. So this is slightly different. You've got Ellen, a 27-year-old. She presents to ED with bilateral lower abdominal pain for the past 5 days. So what sort of questions do you want to ask Ellen in your history taking? Yeah, Socrates, yes, for your pain history. Anything else that you want to? Abnormal bleeding, good. So all of your gynae symptoms. Has this happened before? Yeah, always useful. LMP, yes. Sexual history, very good. Vaginal bleeding, vaginal discharge, history of dyspareunia, definitely. Pregnancy, contraception, good. Obstetrics history as well. Yeah, so basically everything that you guys have mentioned. So Socrates, you've done, it's a sharp pain, 8 out of 10, no radiation. She feels nauseous with the pain. She has had some slight vaginal bleeding and brown discharge. She's had pain during intercourse as well. With regards to her sexual history, she says she's got a new sexual partner last month. She rarely uses condoms. She has had previous STIs treated for chlamydia and gonorrhea. What sort of examination would you guys do? And what might you find on examination? Bimanual, yes. Abdo exam, yep. Speculum, you can do, yes. Excitation of the cervix, yeah, that's something that you would find in this presentation. Yeah, urine dip as well, definitely. That's probably your first line investigation. Swabs for STI, good. So, oh yeah, forgot to say, no significant past medical history, no drug allergies. So on examination, she's got a temperature, but otherwise she's tachycardic as well, actually. Her blood pressure is maintained, normal rest rate. So after exam, she's got signs of lower abdominal peritonism. Bimanual examination, she's got bilateral adnexal tenderness, she's got cervical excitation, and so let's just say, in this case, you're not able to palpate a mass, but sometimes you can palpate a mass, especially if there's an abscess there. So investigations, you guys have mentioned already. So you do a pregnancy test, you do swabs, exactly like you guys said for chlamydia, gonorrhea, and especially because this patient's spiking, then you would do the sepsis 6, do your blood cultures, full set of routine blood tests, and you would do a pelvic ultrasound scan as well. And why you do that? So I mean, in this case, if she's got negative pregnancy, it wouldn't be to rule out an ectopic, but it can help you rule out an abscess because you can get that as a complication. It can help you exclude an ovarian cyst as well. So differentials in this case, so you've got gynecological, so things like ectopic pregnancy, ovarian cyst accidents, you've got appendicitis as well, but it's bilateral lower abdominal pain, so it's very low, it's much lower down in your differentials. So what do you think is going on with this patient and how do you manage her? Yeah, PID, yes, exactly. So that's at the very, very top. That's very likely, especially considering her sexual history. She's had previous STIs. She doesn't really use any contraception. She rarely uses condoms. PO antibiotics, and if it doesn't improve, do you admit for IV? Yeah, so essentially the thing is, so you would give her antibiotics, exactly. I think because she is quite tender and because it depends on what her bloods show, but she is spiking in the department. So, the question is, would you admit? So I think you'd give her analgesics, you'd give her antibiotics as well. And essentially with PID, you basically classify the PID into mild, moderate, and severe. If it is severe PID, so by that I mean if she's hemodynamically unstable, I mean, she's pyrexic, she's tachycardic, so she is likely to come in unless she improves dramatically in the department, which is unlikely. I think she'll probably be referred to gynae in this case, and they will admit her for some IV antibiotics. So yes, if she's pyrexic, clinical signs of tubo-ovarian abscess. Oh, and also she's parasitic on examination as well. You probably wouldn't want to send someone home. So you'd give her IV Kef, Doxy, and Metro. And basically consider LAP if there's no significant improvement after 24 hours. And if there is a pelvic abscess, so you do see an ultrasound scan. And if they're not improving on antibiotics, then you might have to do a LAP or an ultrasound guided drainage. And again, because she has a regular partner, then you basically want to treat the sexual partner as well. Are there different swab types, high vaginal or endocervical? I think they usually just do the high vaginal swabs from what I've seen in gynae. There are different types that you can do, but I think they just send high vaginal swabs. So essentially, these are empirical antibiotics. So because with PID, I'm going to come on to that, it's usually polymicrobial. So you want to start off on something quite broad. So these are all quite broad spectrum antibiotics. Is AMG antibiotics only given to lower GI infections? Not sure what AMG is. Yeah, I'm not sure what you mean by AMG. But yeah, you basically want to give broad spectrum antibiotics. So I think the partner would also get similar antibiotics. It's a good question. I've never actually thought about what exactly you'd give the partner, but I think it possibly gave them the same thing as well, depending obviously if they're allergic to anything. But similar cover for the partner as well. So with PID, essentially, this is some of the complications of PID. So you can get what they call like a frozen pelvis. So you can get lots of adhesions because of the inflammatory process. And you can get swelling of the tubes. So you can get hydrosalpinx, which is why you've got fluid sort of like blocking the tubes essentially. And the pathophysiology is you can get ascending infection from the cervix, often due to STIs. And this can result in infection and inflammation of female pelvic organs. But someone doesn't have to be sexually active for them to get PID, because you can also get PID. You can get that inflammation as a result of other infection to surrounding organs. So like you can get it from like appendicitis can sort of like spread to the pelvic organs as well. But most commonly it is secondary to STIs. So it's really important that you do take a sexual history and pick up any high risk factors. So risk factors are prior STIs, recent new sexual partner, they're having multiple partners, unprotected intercourse, and if they had a history of PID. So most common organisms are chlamydia and gonorrhea, but often you can't really find a cause, which is why it's really important to give them quite good microbial cover. And yeah, so as I mentioned, it's the inflammation that gives you the scarring, adhesions, partial or total obstruction of the fallopian tubes. There's loads of different complications of PID, and this is just a mnemonic that you can remember to sort of think about the different complications. Do you guys know what this ultrasound scan shows at the top? That's one of the complications of PID. So not a hydrosalpinx. Let's say this patient is, tubo-ovarian abscess. Good. Yeah, and do you guys know what the temp, so I was just gonna say, you can basically get like a swinging pyrexia if you've got an abscess. Yeah, they would definitely be spiking. They wouldn't be improving on antibiotics. So this might be the kind of patient that you might end up doing a laparoscopy on because they're not improving. And also you'd see it on an ultrasound scan, as I mentioned. And what about the picture underneath? What is this syndrome called? Yes, Fitzhugh-Curtis, exactly. And it's basically, all you get is right upper quadrant pain secondary to these adhesions between the liver and the anterior abdominal wall. So the I stands for infertility. And the infertility is secondary to all of these adhesions because of the blocked tubes as well. So in your fertility history, we're going to come on to that. It's really important to ask about, previous STIs, PID, because all of those are increased risk of problems of fertility later on. A for abscess, C is chronic pelvic pain, E is ectopic. So it's one of the risk factors for getting an ectopic pregnancy. P is peritonitis, I is intestinal obstruction. So the adhesions can give you intestinal obstruction. Secondary to that, and D is less commonly seen because we're quite good at picking up PID, or we should be, and it's less likely to present with disseminated infection. But in rare cases, you can get endocarditis, sepsis, meningitis as a complication of PID. Okay, so what are some of your, just a quick recap, what are some of your gynae differentials for acute pelvic pain? Ovarian torsion, yes. Anything else? Miscarriage, yes, possibly. Ectopic, good. Always rule out an ectopic in acute abdominal pain, yes. Endometriosis, yeah. Now, it's likely to give you acute abdominal pain, but on a context of chronic abdominal pain, yes. Cyst rupture, yes. Really important. So what have I put down? I've put ectopic pregnancy, yes. Miscarriage, and ovarian cyst accidents. So rupture, torsion, hemorrhage, and PID as well. And Mittal Schmutz, yeah, you can always put that in your differentials. And what about some of the non-gynae causes? So let's think laterally, outside of gynae. What are some things you need to rule out? Appendicitis, yes. UTI, yes, really important. That's what I wanted to say. So always do a urine dip for these patients as well. And it could always be some surgical pathology as well. Good. So yeah, appendicitis and urinary thing. That's why I wanted to just point out with this slide. So always think about stones, urinary tract infections. So always ask about urine and bowel symptoms with anyone coming in with acute pelvic pain. Okay, so this is the next one. Let me just see. Yeah. Okay, so how would you manage this lady with PID? Sorry. If we can show the answers now. Okay. Amazing. So most of you guys got that right. So why did you guys think about oral antibiotics as opposed to IV in this case, compared to the one that I presented to you before? So I see SMA ischemia, which is a very rogue differential, but yeah, possibly for acute pain. Systemically well, hemodynamically stable, yes. No adverse features, good. Yeah, essentially no signs of peritonism, no vomiting, exactly. So I think with them, with this patient, sorry, you could just give them oral antibiotics, safety net them to come back if things get worse. But yeah, this is just to let you know that it is a spectrum with PID and not everyone needs to be admitted for IV antibiotics. There are definitely patients that you can send home on oral antibiotics. Okay, so yeah, that's the answer. So the answer is C for this one. Okay, so case 2, painful periods. You've got a healthy 25-year-old woman presents with worsening dysmenorrhea. It's not managed on NSAIDs. She's had pain of recent onset in the left lower quadrant, and she's got pain during sexual intercourse as well. She's got regular menstrual cycles, and her last menstrual period was 3 weeks before presentation. So what do we think is, this is not an SPA, but what do you guys think might be going on with her? What's your differentials for this lady? Yeah, endometriosis would be quite high up in this case. And why do we think endometriosis as opposed to like a physiological cause of her painful periods? Because painful periods are sadly very common, but what are some of the things that that you're worried about? What are some of the additional things that make you think this is more than just a regular painful period? Yes, adenomyosis as well. Yeah, very true. That's another good differential. Fibroid as well can give you pain, yes. Not managed by NSAIDs, exactly. I think that's quite, I mean, usually if it's, physiological pain, it will be quite well managed by NSAIDs. Not always, but most commonly. Pain during sex, exactly. Good. And this recent onset pain in the left lower quadrant as well. So I think it's definitely something that you would take seriously and you'd want to do more. You'd want to do further investigations. So yeah, we've gone through some of the gynecological causes. What do you think is most likely going on? I agree, endometriosis would be quite high up. So just some differentials for dysmenorrhea. So you mentioned primary dysmenorrhea, and also in the history, this usually coincides with the start of menstruation. Again, it's quite common, but it does respond to NSAIDs or COCP, which sort of like suppresses ovulation, so therefore you shouldn't be getting this pain. Secondary dysmenorrhea, basically pain usually precedes and it's relieved by the onset of menstruation. So the history is slightly different to the primary dysmenorrhea. And you'd also get things like pain, like deep dyspareunia, you get menorrhagia, you can get irregular menstruation as well. And you've got endometriosis, definitely. Adenomyosis, which is where you've got endometrium, but present within the myometrium. And the uterus will be mildly enlarged. The diagnostic scan is an MRI, but you can sometimes pick it up on a transvaginal scan as well. But it doesn't have a very high sensitivity. But again, fibroids you guys have mentioned as well, and PID. And some ovarian tumors possibly can present with dysmenorrhea. So yeah, these are all of your differentials for secondary dysmenorrhea, and just the history is slightly different. So the pain is relieved by the onset of menstruation. Okay, so we've got a lady who's come in with history of painful regular periods, and since stopping the COCP, they've become more painful and heavy. She's upset, she'd like to conceive, but the pain is limiting intercourse. On examination, her abdomen is soft, and it's non-tender with no masses. Bimanual is limited because of pain. The important thing, I guess, in this question is what's the gold standard diagnostic test for this woman? It's often not what actually happens in clinical practice, but they're asking you what the gold standard is. Give you guys a couple more seconds. Okay, so if you can show the answers. Yeah, exactly. So I think we were all thinking endometriosis in this case. I mean, in real life, she would have a transvaginal scan first, and then she'd have all of the less invasive investigations, but it says gold standard diagnostic test. So yeah, you would go for laparoscopy. But often what we have found is you've got patients who come in with debilitating pain and they have a laparoscopy that's actually not, doesn't coincide with their symptoms, which is really distressing for the women. But unfortunately, that is what happens. You can have like a pristine pelvis, but this patient is still in a lot of pain, which is, I think, the real challenge with patients with endometriosis, sadly. And also there's a lot of delay as well. Apparently there's like, I think I've put it on my slides in the next slide. It's like a 10.5 year delay between presentation and actually diagnosis of endometriosis, which is just quite sad. So what is endometriosis? You've got endometrial tissue that is outside of the uterine cavity. And essentially it responds to the hormonal fluctuation of the menstrual cycle. So you've got the 4 Ds of endometriosis. You've got dysmenorrhea, you've got dyspareunia, you've got dyschezia, which is pain on opening the bowels, and dysuria, so pain on passing urine as well. And that's because you can get those endometriosis deposits and you can get that inflammation and the scarring and adhesions in the surrounding organs as well, which is why in a gynae history, it's always important to ask associated urine and bowel symptoms. So yeah, so you can get all the 4, I just remember as 4 Ds. And essentially it's just pain. So pain during periods, pain during intercourse, and then pain during or while opening your bowels and passing urine. So just remember pain with endometriosis. And on examination, you can get a fixed retroverted uterus, pelvic tenderness, enlarged ovaries. And investigation, you do a transvaginal scan first. And on a transvaginal scan, you might see endometriomas, which are like your chocolate cysts. So it's basically altered blood. And sometimes if you do a laparoscopy and you rupture the cyst, you can just see like it's called chocolate cyst because of the presence of the blood, altered blood inside. And yeah, as I mentioned, it's over 10 years between onset of pain and surgical diagnosis, and laparoscopy is the gold standard. And what you might see on laparoscopy, you might not, but what you might see is all these foci. So you might see these endometriosis spots, you might see adhesions, you might see endometriomas as well. And you can see this again, frozen pelvis appearance, as you might see in PID. And management essentially is you can do hormonal treatment, so like COCP, Mirena, progestogens. All of these are just to suppress ovulation, which should hopefully, and it suppresses like the hormonal fluctuation as well, which should hopefully help with the pain. And it's just, if it's chronic pain, it's just like chronic pain management essentially. And surgery, you can do lap ablation, you can do adhesiolysis, but the more you do procedures, the more you have risk of adhesion. So there is that risk with doing surgery in these patients. But obviously if there's any concerns with fertility, then you would try to do some procedures, it's something to sort of like help with the fertility. And complications is, yeah, with endometriosis, you can get ovarian failure post-treatment, you can get formation of adhesions and infertility. So those are some of your complications. So let's just see before we move on. Does anyone have any questions? Oh, there's quite a lot of questions. Oh, dyschezia is pain on opening the bowels. Yeah, thanks, guys. Hematochezia is bleeding when you're opening your bowels. Yes, that's sort of like blood in the stool. How is endometriosis investigated in real life if not laparoscopically? So for gold standard, you would do a lap, but before that, you sort of like try to do, you do a transvaginal scan. You would try and manage them with combined oral contraceptive pills, you'd give them pain relief. And if all of those things don't work, then you'd consider laparoscopic surgery. So yeah, the only thing is, so the gold standard is lap, but before that, you'd obviously try everything else. So what's first line management? So you would do COCP. If you do want to get pregnant, then it does become a bit more tricky. So I think it would just be pain management in that case. That's all you can do, really. If you are struggling to get pregnant, then you'd go down the infertility route and you might do some surgery to see if that might help and increase your chances of getting pregnant. Okay, so let me just see if there's any questions that I've missed out. Yeah, okay. So what are some of the questions that you guys would ask in a sexual history? What are some of the important things to ask? It can be quite awkward to ask them. So I think it's just the more you sort of normalize asking people these questions and just let them know that these are questions that we ask all patients. It just becomes a little bit more. Yep, ask if they're sexually active first. Definitely, that would be a good first question to ask. Previous STIs, whether they've been treated. Good. Any other questions? Regular partner, how many sexual partners in the last 3 to 6 months? Or type of sex as well. Yes. Contraception, good. Anything else? Do they use protection? Yeah. Recent STI screen, good. Condom use, yeah, exactly. So key symptoms you want to ask about are pelvic pain, bleeding, so post-coital, which is PCB, intermenstrual, so in between periods, and postmenopausal bleeding as well, if relevant. Abnormal vaginal discharge, so you want to ask if it has a funny odor, the consistency, the amount, the color of the discharge as well. You want to ask if there's any pain during sexual intercourse, any skin changes, any itching, and systemic symptoms as well. So sexual contacts, you want to ask them, I mean, yeah, the last sexual encounter, was it consensual? Are they with a regular partner, or do they have multiple partners, the type of sex and contraception? And again, any partners in the last 3 months, which you guys have mentioned already. And with regards to a HIV risk assessment, essentially you just have to ask if they've been with any previous partners who are known to be HIV positive, do they engage in any recreational drugs, all of those questions as well. Yeah, and you want to know as well if they have sex with, like, if it's just males, or do they have sex with, like, if it's with the opposite sex, the same sex, sorry. And yeah, so you want to ask if they've been abroad recently, all of those questions. Good. So what do you guys think are the most common differentials when it comes to vaginal discharge? Yeah, BV is quite common. Yeah. Anything else? Thrush. Good. What's TV? So there's so many differentials. I did so many like abbreviations. Is that trichomonas? Okay, fine. All right. BV, Candida. Yeah, so that's basically all the ones that I had on here. So the most common causes, I mean, physiological as well. Do you guys know when you might get increased vaginal discharge? What are some of the things that can increase it? Pregnancy, yes, good. So it's common to have increased vaginal discharge during pregnancy. Ovulation, yes. Anything else? Any other medications? So COCP as well can give you increased discharge in some people. So other common causes, Candida, you guys have mentioned already, Trichomonas vaginalis or TV, and bacterial vaginosis, yes. And some of the key features of these common causes. So with Candida, you'd get the itching, you'd get vulvitis, you get cottage cheese discharge. The patients probably will not use cottage cheese, but they'd say white discharge. Trichomonas is the only one that's sexually transmitted. It gives you an offensive yellow-green frothy discharge. And on speculum, you might see a strawberry cervix appearance. BV is not sexually transmitted, but it's almost exclusively seen in patients who are sexually active. And do you guys know the criteria that you can use for BV? AMSEL, yes, good. And we'll come on to what exactly that makes up the criteria. And with BV, it's often worse with intercourse, and you have this fishy odor to the discharge. So less common causes, gonorrhea, chlamydia, ectropion as well. And we've mentioned before what an ectropion is. So it's basically where you've got the columnar cells on the inside of the cervix get exposed on the ectocervix. And it most commonly presents with postcoital bleeding, but can present with vaginal discharge as well, and foreign body, which you'd get from the history. And cervical cancer, again, less commonly, more commonly presents with intermenstrual or postcoital bleeding. So non-sexually transmitted infections first. So BV we've mentioned, and BV is basically where you've got the loss of the lactobacilli, which are normally in the vagina, and you've got increase in anaerobic and BV-associated bacteria. So you've got AMSEL's criteria, like you guys mentioned, and essentially you've got thin white discharge, you've got clue cells, and this is basically what clue cells look like. It's essentially just vaginal cells with the bacteria stuck on them, and that's what they look like under the microscope. You've got a vaginal pH of over 4.5 and a positive whiff test. I think it's potassium hydroxide, from what I remember. That's what they use. So Namrata has asked, would you use metronidazole to cover both TV and BV? Yes, you do. And management is oral metronidazole for 5 to 7 days. And what are some of the risks in pregnancy of having BV? Miscarriage, yes. Anything at preterm. So any infection in pregnancy increases the risk of you having preterm labor. Yes, good. Chorioamnionitis as well is another risk factor. Yes, that I just wanted to just point that out. So those are some of the risks of having BV in pregnancy. Candidiasis, so risk factors are again pregnancy, immunocompromised, diabetes. So that's an important point to know. If someone is coming in with recurrent thrush, it's important to check their HbA1c and just delve a little bit further to just make sure this person doesn't have untreated diabetes, because that could be the first presentation. If they're on repeated antibiotics, and that could increase their risk of getting candidiasis. Again, cottage cheese discharge, you've got the itching, superficial dyspareunia. They can get pain on urination as well, so they can get some urinary symptoms. You can either get clotrimazole pessary or oral fluconazole. So again, let's go back to pregnancy. What if you've got candidiasis in pregnancy? What would you give of the two options that I mentioned below? Pessary, you wouldn't give oral fluconazole. And why would you not give oral fluconazole in pregnancy? Yeah, teratogenic. So it's been linked to some defects essentially, which is why you give clotrimazole pessary. Yeah. And moving on to STIs. So you've got chlamydia, gonorrhea. So with chlamydia, you can get altered vaginal discharge. You can get irregular bleeding, so intermenstrual or postcoital. You can get abdominal pain, dyspareunia. Complications are PID, but the PID can be silent, so it can progress to tubal damage and infertility. It can precipitate reactive arthritis. So it's the can't pee, see, or climb a tree is how I remember it. So you've got urethritis, conjunctivitis, and arthritis. And that can be a complication of chlamydia. And you treat it either with a single dose of azithromycin or 7-day course of doxy. And then gonorrhea is usually asymptomatic, but it can again give you vaginal discharge. You treat it with a single IM KEF dose, or you can give them a single dose of oral KEF or azithromycin. And you can, and another risk is basically getting disseminated gonococcal infection if it's untreated. Okay, so what do you guys think of this picture down there? So you've got these ulcers basically on your hands. You've got these like painless warts on your hands. What do we think the spot diagnosis is? Oh, Mark, I'm happy. I'll be sending out the slides. But yeah, I'm happy to go to the previous slide if you want me to. But yeah, you guys will have a copy of the slides, so don't worry about like missing stuff out. So you guys can have a look at it with a bit more time. And I've got a summary table as well, which looks at all the different STIs and how you treat them and how they would present. So yeah, syphilis, exactly. That's what. And what about the picture on the left with the cervix that looks a bit red? It's got spots on it. Yes, trichomonas. Sorry, I keep saying TV and I get confused. Yeah, trichomonas. Or trichomoniasis. So it's vaginal discharge. You see the strawberry appearance of the cervix, pH of over 4.5. And same as BV, you would treat trichomoniasis with oral metro for 5 to 7 days. Next, you've got genital herpes, which gives you painful genital ulcers. You treat it with oral acyclovir. And if you've got primary infection after 28 weeks of pregnancy, then you do an elective C-section. If it's before that, I think the theory is that the baby would sort of be immune to it. So I think it's before that it doesn't really pass on to the baby, I think. Whereas like after 28 weeks, if you are going to do vaginal delivery, then the risk of it passing on to the baby is quite high, which is why they do an elective C-section, from what I remember. I might be wrong. Syphilis, so you can get these ulcers, which I can never pronounce, and then you can get lymphadenopathy as well. Secondary syphilis, you can get a rash, you can get painless warty lesions, and tertiary syphilis, you can get aortic complications, you can get aortic regurg, you can get neurological complications, so the weird and wonderful tabes dorsalis, you can get these inflammatory sort of like bodies or these gammas as well across your body. So how do we treat syphilis? What's your first line management? Yeah, Ben-Pen, exactly. I don't know what they give if you're penicillin allergic, but this is the first line. I am penicillin. I'm sure there's like a second line treatment. So this is just a useful sort of like Venn diagram from past med, because I used to get confused between the two. But the main differences are the strawberry cervix. Trichomonas is a STI. BV is not an STI, but you treat them both with metronidazole basically. And BV, you've got the Amsel's criteria and you've got the clue cells. And the color of the discharge is different as well with BV and with trichomonas. And yeah, as I mentioned, I'll be sending the slides around anyway, but this is just a summary slide for like revision purposes, just comparing the different STIs and non-STIs, how they would present, and then what you would treat them with. Okay, so question on vaginal discharge. So you've got someone who is diagnosed with BV. She's got offensive smell and discharge. They've taken swabs. Which of the following organisms is not likely to be the cause? Okay, so if we can show the answers now. Okay, so yeah, so again, just make sure you just read the question properly. So it's not likely to be the cause. So the answer is trichomonas, because that's different to BV. That's the STI as we mentioned before, and all of these other ones are basically BV associated bacteria. So these are the ones that basically you've got the loss of the lactobacilli and you've got growth of all of these bacteria, which contributes to the patient having BV. So yeah, that's just something to keep in mind. Yeah, the answer is D. Okay, so management of vaginal discharge. So we'll go through these quite quickly because I realize we're swiftly running out of time. But you've got someone who presents with thick cottage cheese-like discharge, no other symptoms. What's the most likely diagnosis and what would you treat her with? Candidiasis, good. And what would you give her? Fluconazole or clotrimazole pessary, good. The next one, she's got offensive, fishy, thin, gray vaginal discharge. Testing the pH it's over 4.5. What's the diagnosis and what would you guys give her? BV, yes. And what would you give her? Metro, good. And next one, offensive, musty, frothy green vaginal discharge. You see strawberry cervix. So I feel like we've gone through this loads of times. TB, yes, good. And again, Metro is what you'd give. And lastly, you've got thin, purulent, mildly odorous discharge. You've got all of those symptoms, and then gram-negative Diplococcus. So what's your diagnosis for gram-negative Diplococcus? Gonorrhea. Good. And you'll give them KEF. Yeah, I've got the answers on there. Yeah, don't worry, I'll be sending the slides across. Okay, so moving on to contraception. Which of the following would be your first line emergency contraception for this girl who's presenting with a history of unprotected sexual intercourse? That's okay, don't worry. Yeah, so if you can answer on the poll. Yeah, that's fine. If you can show the answers now. Thank you. So yeah, so most of you guys got that right. So just to clarify, why would we give her, I mean, it's not going to be A because that's not an emergency form of contraception. It's not going to be D or E, but why would we give her a copper IUD as opposed to giving her levonorgestrel? Because she's within the window for both of them. Yes, interaction with carbamazepine. Yeah, because she's got an enzyme inducer. So it's going to make the levonorgestrel less effective. So the first line, you'd offer her the copper IUD first. I think there was something about how you can give her a higher dose of levonorgestrel, but if they've given you copper IUD as one of the options, that would be the first one that you'd offer her. So quickly, we'll just go through some of the different forms of contraception. So you've got your hormonal, your non-hormonal methods. So with contraception, it's a really good one to go through, especially because I remember we had a station in our OSCE where we had to counsel a woman about the different contraceptive methods. So it's just a good one to know how to counsel someone with regards to like the missed pill rules or some of the side effects. Yeah, so like both from an OSCE and a written perspective. So this is a really good picture actually for the missed pill rules for the COCP. So how does it work? It prevents ovulation, common side effects, breakthrough bleeding, headaches, migraines, breast tenderness. You can get improving or worsening acne. What are some of the UK MEC4 criteria for the COCP? Because there's quite a few, but what are the main ones that you want to get from your history? Because it's really important that you ask about them. Migraine with aura, perfect. That's always the first one. that everyone remembers. Breast cancer, yes, over 35 and smoker, very good. That's something that I always forgot. Breastfeeding under 6 weeks, yes, good. Unprovoked VTE. Yeah, you guys basically have got, I think, almost all of the UK MEC4 criteria. Good. So those are all the ones, remember to ask them in your history. And when do you start the pill? Usually within the first 5 days of your cycle. If you started later, then you need alternative contraception for 7 days. Some of the risks are hypertension, thrombosis, increased breast cancer risk, but it's said to be protective against endometrial and ovarian, possibly colon cancer as well. UK MEC4 criteria, I think we've gone through all of them. So breastfeeding, age over 35, smoking over 15, uncontrolled hypertension, history of stroke or ischemic heart disease, VTE, breast cancer. Oh, we forgot severe liver cirrhosis as well is another one. So the POP, how does it work? So it increases your cervical mucus and it thins your endometrium. The new POP, desogestrel, which is Cerazette, that also inhibits ovulation in addition to these other two mechanisms. And common side effects. So the side effects are actually quite similar across the different forms of contraception. So just remember some of them, then you can basically say they're the same for most of them, basically. Irregular bleeding, again, same as a COCP. You've got breast tenderness, libido changes, acne, headaches. And POP is basically taken daily at the same time with no breaks. Whereas the COCP, there's different ways of taking it. So initially, everyone used to take it with 21 days with a 7-day break, but you can actually take it back to back. And there's some evidence to show that you only need maybe 3 or 4 bleeds during the year in order to maintain a healthy endometrium. So there's different ways of taking the COCP, but the POP, you definitely have to take it with no breaks. You need to take it daily at around the same time. So with the missed pill rule, so for the traditional POPs, there was a 3-hour window, but for desogestrel, which is what most people are on these days, there's a 12-hour window. And outside the window, you take the pill as soon as you remember, take the next pill at your usual time. And you need to have extra contraception for the next 2 days. If you've had unprotected sexual intercourse, you need to seek emergency contraception. And with the implant, so it's a small flexible rod inserted subdermally in the arm. It lasts 3 years. And the way it works is similar to the POP. So it stops ovulation, increases mucus, and thins the endometrium. And common side effects, you can get spotting with the implants. That's an additional one to remember with the implant. The depot is the only one that's shown to actually cause weight gain. That's a concern that a lot of women have, but this is the only one that's actually been shown to cause some amount of weight gain. It's a 3-monthly IM injection. It works the same as the POP and the implant. And common side effects, so the weight gain, and also remember the delay in fertility as well, so up to 12 months. And you don't really tend to start depots in adolescence because it increases your risk of osteoporosis. So the IUD you guys will know about already. So you've got the Mirena, the copper coil. Mirena sits in the uterus and the cervix, slowly delivers levonorgestrel, lasts for 3 to 5 years. Again, it works in the same way as your progesterone only and the implant. So thickens cervical mucus, thins endometrium. It's quite good for menorrhagia, as we mentioned in our last session. And you need contraception for 7 days after insertion. Copper coil, its mechanism is slightly different, so it reduces sperm motility and survival. Benefits is effective immediately. It can be used as emergency contraception. And if women have a VTE, breast cancer risk history, it's non-hormonal, so it's good for those women. Side effects, it can, however, give you heavier and more painful periods. And pregnancy with an IUD or an IUS in situ is more likely to be ectopic. So by IUD, I mean intrauterine device. So special cases of contraception, what would you give someone postpartum? What are the forms of contraception that we can give them? POP, yes. Lactational amenorrhea, yes. That is a form of contraception, I guess. IUD, you can insert either within 48 hours or 4 weeks after. So yeah, so most people tend to we usually sort of, when we did the postnatal reviews, we'd offer them either the depot or we'd give them the POP. Most people went for the POP. They are not needed for 21 days, but we usually tended to start them straight away. Just because, once women go back with the baby and they're busy, they're tired, it's probably better to start them on it straight away and they're more likely to continue. So POP and depot are safe with breastfeeding, can be started at any time. COCP we've mentioned is contraindicated if you're breastfeeding and if you're under 6 weeks because of the risk of it transmitting into the breast milk. IUD, IUS either within 48 hours or after 4 weeks. So emergency contraception, we've mentioned the levonorgestrel, and it's got a 72-hour window. The ulipristal, which is a progesterone receptor modulator, up to 5 days, and caution in severe asthma for that one. And copper IUD again is 5 days, and yeah, that's another form of contraception. Yeah. Emergency contraception, sorry. And a really useful resource is OSCE-Stop, and it's got a really good table looking at the method, contraindications, the side effects, and some comments on like missed pill rules as well. That's a good one before you guys, when you guys are practicing for your OSCE stations. So quick quiz, guessing the contraception. So which contraception is contraindicated in a patient who has migraine with auras? COCP, exactly. Which one do you have to take regularly without any breaks? Perfect, good. Which results in a delay in fertility? Depo. Most effective form of emergency contraception? The copper IUD, yes. And which is useful for menorrhagia? Marina, good. So let me just check. Okay, so we're almost done. We're in our last section now. So we're going to go through taking a fertility history, PCOS, and ovarian hyperstimulation. Yeah, and hopefully we should finish on time. So what are some of the questions you want to ask in a fertility history? That's again another potential OSCE station that could come up. What sort of questions do we want to ask them? Previous children, that's really important for both of the partners. If they've had previous children before. Past Obs and Gynae history, definitely. Yeah, are they having regular sexual intercourse is a really important question to ask. How long have they been trying as well? Yes. History of STIs, contraception, family history, stresses in life. Smoking is another really important one to ask. Good, PCOS, because that's a really common cause for infertility, actually. Good, so how long have they been trying? Intercourse frequency, any pain during intercourse, partners. You consider each separately. You want to know their age, occupation, BMI, previous children, smoking and alcohol, any current medications, ask about their past medical history, do a gynae history, as you guys mentioned. And so when we look at fertility, especially from like the female perspective, there are 5 different factors you want to examine. So are they ovulating? If there's any problems with ovulation, could this be PCOS? Do they have any uterine abnormalities? So things like, for example, if you've got submucosal fibroids, that can give you infertility. Do they have any tubal factors? So are there any tubal blockages? Is the tube blocked with fluids over if you've got hydrosalpinx secondary to PID? Is it male factor infertility? So is there any problems with that? So that's why you always do a semen analysis as well. It's one of the initial investigations that you would do for everyone, every couple that comes in. Is there a peritoneal factor? So is there any endometriosis present? Those are basically the 5 main things that you want to think of when it comes to differentials for infertility. And investigations that you would do. So you do your semen analysis, you do mid-luteal progesterone, you do FSH and LH, and then you'd move on to do, if you want to assess the patency of the tubes, you can do lap and dye. You can also do like an ultrasound scan where they put the dye in and they basically watch it coming out of the tube. So basically check the patency of the fallopian tubes. So here's a question. So someone has come in, they've been trying to conceive for 4 years. What do we think is the most likely cause of a subfertility? And I've got the normal levels on the side because the question, very unhelpful in providing normal values. So yeah, here's the normal values on the side. Oops, sorry. That was not supposed to happen. But yeah, so the answer was D for this one. So essentially the reason why it's hypothalamic hypogonadism is because you've got low LH and low FSH. And essentially that's the reason why she's been having no periods whatsoever. It's not anorexia because her you would do other things. It's not just a BMI diagnosis, and you don't really have any history of, you don't have any clear history of anorexia from that alone. So essentially the cause of her symptoms are more likely to be hypothalamic hypogonadism. With PCOS, you're more likely to get things like irregular periods. You might get some other symptoms like features of hirsutism. They might give you an ultrasound scan that shows cysts in the ovaries. So we're going to come on to that, but you've got a criteria for diagnosing PCOS. But in this case, it's more likely to be hypothalamic hypogonadism as a cause for her infertility or subfertility. So second one, you've got a 27-year-old woman. She's been struggling to conceive, and you've got a hormone profile taken on day 6 of her cycle. And it's got normal LH, normal FSH, testosterone is mildly raised, and you've got this ultrasound scan. Do you guys know what this scan finding is called? So what are the causes of hypothalamic hypogonadism? That's a good question. So anorexia can cause it as well. Any kind of acute stress. You can see it in athletes. So if someone has a really, really low weight, then that can get, you can get that as well. If they've got very low sort of like body, like muscle mass, then you can get that. So it's like stress. You can get it in athletes. There's lots of different causes. String of pearls, yes, good. And the question, sorry, it's an MCQ. So which single set of symptoms is she most likely to have out of these? So the clue, I guess, is most likely. Oh, sorry, if we can put the poll results back on. All right, it's fine. If people are answering on here, that's okay as well. So yeah, so in this case, most likely is oligomenorrhea and facial hair. Even though they can have infertility, they can have pelvic pain, but the most likely is C. And temporal headaches, you're more likely to see that with something like prolactinoma, for example. Yeah, so C is the answer for this one. So going through PCOS, so features, you would get subfertility, or you can get infertility, you get menstrual disturbances, oligomenorrhea more commonly than amenorrhea. You can get hirsutism, acne because of the high levels of peripheral testosterone. You can get obesity as well, acanthosis nigricans. And that's sort of secondary to you can get a form of insulin resistance with PCOS, and that's why you can get acanthosis nigricans. Investigations, you want to do imaging, you want to do pelvic ultrasound, you want to do testosterone, you want to check for IGT as well, so glucose tolerance test. And the reason why you do that is because of the insulin resistance that these patients can get, and they can go on to develop diabetes. They're at increased risk. So you've got the Rotterdam diagnostic criteria, and essentially you need 2 out of the 3. So either clinical or biochemical hyperandrogenism. So things like hirsutism or an increased testosterone level, then oligomenorrhea and polycystic ovaries on ultrasound. So you only need 2 out of the 3. So it's very common to have cysts on your ovaries or a polycystic appearance of your ovaries, but to actually have the syndrome, you need to have something more. You need to have this irregular periods, you need to have the hypoandrogenism state. And with regards to management, what are some of the management options that you can get with PCOS? Weight loss, yes. So always start with conservative, medical, and then you don't really tend to do surgical, but yeah. So conservative first. Good. So a lot of people have mentioned metformin, clomiphene, if they're trying to conceive. Good. So that's some of the ovulation induction options. So yeah, treatment of oligomenorrhea, you can give them the COCP. It regulates menstruation, and some forms of COCP can help with the hirsutism symptoms as well. Lifestyle interventions. So lifestyle interventions are really important because it can improve the acne, it can improve hair growth, because you can get male pattern balding with PCOS. It can regulate your periods, it can improve your fertility as well, actually, having a healthy BMI. Infertility, so ovulation induction drugs. So what are some of the ovulation induction drugs that you can give for patients with PCOS? We mentioned clomiphene already. Is there anything else that we can give? Letrozole, good. How does letrozole work? Yeah, so it's an aromatase inhibitor. And basically both, clomiphene is a progesterone receptor I think it's an estrogen receptor modulator, sorry. So essentially what both of them do is it stops. So what estrogen basically has a negative feedback sort of like mechanism. It has negative feedback loop essentially. So it decreases the levels of FSH and LH. So yeah, so letrozole, it prevents the conversion of androgens to estrogen. And what both of them do, basically it prevents this negative feedback loop. So you've got increased levels of GnRH, which basically you've got those pulses. So you've got increased levels of FSH and LH, and basically you're trying to stimulate the ovaries to ovulate, essentially. So you're trying to promote ovulation by reducing the negative feedback loop. That's how both of them work. But do you guys know which one is preferred over the other? So do we use letrozole or clomiphene, which I didn't actually know. I had to look this up. And apparently, I think it's changed recently. So they apparently use letrozole now because clomiphene has a lot of side effects, and you're more and you can get things like hyperstimulation syndrome. You can get a lot of like nausea, abdominal pain, vomiting, all of those things with clomiphene. So I think and also the success with letrozole. So it's more successful at ovarian induction than clomiphene. It's been shown to be. So letrozole is now used first line, which which was different when I was studying during my ONG rotation. So yeah, so they're using letrozole now first line and then clomiphene. But you can use both of those drugs. How does PCOS cause insulin resistance? I'm not actually sure, to be honest. That's something to look up. I don't know exactly why, but I just know that you get this state of insulin resistance. I don't know what the mechanism of that is. So long-term complications. So because they're having these anovulatory cycles, you can get infertility. It also increases the risk of diabetes and GDM. In pregnancy, it also gives you an increased risk of endometrial cancer as well. Okay, so you've got a 34-year-old woman. She has had some fertility treatment. She was injected with a gonadotropin analog, and she's come in with distension, loose stools. She's dyspneic. What do we think is going on? Yeah, so I think the overweight is sort of like a secondary thing because they're insulin resistant. So it's sort of like part of that as opposed to the, I don't think I'm not sure if it's because they're overweight. I think that that's sort of like a result of it. That's why they have difficulty losing weight. But yeah, I'm not sure exactly why. It's a good thing to look up actually. Okay, I'll give you guys a couple more seconds. Okay, so if we can show the answers. So yeah, so all of you guys answered correct. So I was just trying to show the ovarian hyperstimulation syndrome as a side effect of someone undergoing fertility treatment. And do we know what some of the complications are with ovarian hyperstimulation syndrome? VTE, yes, that's a big one to consider, especially when it comes to managing these patients. Good. Fluid and electrolyte shifts, definitely. ARDS as well. So very careful fluid replacement in these patients. Ascites, yes. Good. Yeah, so it's ovarian hyperstimulation syndrome. And the thing to note is that it is a syndrome. So it's a spectrum. And not everyone's going to have all the different complications. And this is just a picture showing you some of the different complications that they can have. And it's a potential side effect. Severe OHSS is seen in less than 1% of patients. Pathophysiology, so you've got ovarian enlargement, you've got these multiple cystic spaces, and you basically have this fluid shift to the extravascular space. And it can give you life-threatening complications. So it can affect your kidneys as well. So acute renal failure, VTA, you guys have already mentioned, hypovolemic shock. And principles of management is anticoagulation, fluid and electrolyte replacement, abdominal acidic paracentesis, if these things don't work. Okay, so that's actually the last slide that I had. Does anyone have any questions about anything that we've covered today? Yeah, so I think that's what they usually do. So yeah, you guys will be given the slides once you fill out the feedback form. And I think a lot of people wanted the answers in the slides, so I've tried to put that in this time. So you'll get all the answers in the next, and like in the within the slides itself. So yeah, next week we're going to cover obstetrics. It's the last session. So we're going to go through stages of labor. We'll go through some complications during delivery. So the breech, shoulder dystocia, cord prolapse, forceps delivery. We'll just go through some of like the first line things that you need to do. You obviously don't need to know a lot, but just what you need to know from like a medical student F1 perspective. And then we'll finish off with GDM, diabetes in pregnancy, and then hypertension in pregnancy. So yeah, thanks so much, guys. Thank you for interacting, for asking all the questions. I hope I tried to answer the questions as much as I could. I believe that there is a recording available for previous sessions, but I think I'll let the team answer that. Oh, someone's asked, where do I get the past paper questions from? So I will put the link to the book up in the next one. I think I've been asked that a few times, sorry. Yeah, so I'll put the book up in the next one. So I think it's, I can't remember exactly the name of the book, but I'll make sure to put it up next time. And the next session will be again next Sunday from 7:30 to 9. And yeah, these are some of the useful resources I've mentioned every time, but if in case this is your first one, this is some of the things that I used. I mainly use this textbook. I think it's really good. It's got some useful like diagrams and stuff. And I used PassMed. I think it's a great resource bank for like notes and also for like questions and stuff as well. So yeah. And is there a link to sign up?
Thank you.
Team will distribute that.